Hello everyone. Hello everyone, and welcome to our Zoom meeting. Today we will have a couple of topics, and the team will be.
Hello everyone. Hello everyone, and welcome to our Zoom meeting.
Yassein will be presenting or will be moderating the team, the speakers. So please, when you are ready, Dr. Yassein, go ahead.
Okay, I think we can start.
Yes.
Assalamu alaikum. Hi everyone. Eid Mubarak and happy Eid for all of you. My name is Yassein Elhussein. I'm one of the Lime team group #1. I'm a graduate of University of Algeria in Sudan. Today we'll be moderating the session on behalf of our team group leader, Dr. Mira Mizoni. And together with my colleagues, we're presenting a couple of presentations. We will present about cardiovascular disease. Will be presented by Dr. Zhor, Tourabi, Dr. Salish, Mohsen, Dr. Riham, Ahmed, and then another presentation about pathway number 6 for A7G certification will be presented by Dr. Mohamed Atif. And I will be presenting about the Microsoft Coach tool. And there is a presentation tutorial on the Canva video will be presented by Dr. Nidhal and Dr. Nidhal later on the presentation. So I think we're ready to start with the cardiovascular disease presentation. I think can you please make me the host so I can share my screen or at least give it to the Dr. Zhor so she can start her presentation. Okay, thank you so much, Doctor.
Yeah, Assalamu alaikum everyone. My name is Zhor Tourabi. I'm graduate from Wahran Medical School. I'm from Algeria. Today I will be presenting a part of topic 1 cardiovascular presentation. We will share me and Dr. Rohan and Dr. Saleh the whole slide. So we try to divide them on 3 parts. It's too short, but try to work together. Okay, I'll try to share my screen. Okay. Just bear with me a moment, please. Sharing just 1 second. I'm just trying to pull that page. Okay. Can you help me, Dr. Yassein? I don't know. I probably choose the wrong page to share.
Okay, no, let me share my screen.
Okay, I'll stop sharing. Thank you.
Can you assign me back as a host? Can you assign? Yeah, sure, thank you.
Thank you. Can you center the, put it as a full screen? Okay, perfect. Perfect. So I just want to make sure before starting that Dr. Rohan and Dr. Saleh are present so they can continue while I'm presenting the slide. Just want to double check if they're here. Can you just guys share if you're here?
Yes, I'm present and I'm going to continue the presentation from the
and Riham is present too. Thank you guys. Thank you for confirming that. Yeah. So hi everyone. Today we're going to share the cardiovascular disease part 1. Next slide, please. So the goal and the objective of this presentation is to be able to describe how the cardiovascular system changes with the normal aging, the sign and the symptoms of the most important cardiovascular disease in older patients, and the appropriate diagnostic test to identify the presence and the severity of cardiovascular disease. Can you scroll back? Can you scroll back? Yeah. And the standard of treating cardiovascular disease. Next slide. Yeah, so on this presentation, we're going to cover only part one. Part one contains epidemiology, effects of aging on cardiovascular function, cardiovascular risk factor, coronary artery disease, acute coronary syndrome, and chronic coronary artery disease. Next slide. So first, we're going to start with the death among coronary resulting from coronary or cardiovascular disease. So among 800,937 deaths in the United States from cardiovascular disease in 2013, greater than 81% occur in adults over or greater than 65 years old, and 65% occur in those 75 years old and older. With the aging of the population, the absolute number of cardiovascular deaths in older adults is expected to increase markedly over the next several decades. Next slide, please. Okay, so this slide here explains data about prevalence of cardiovascular disease. So as we see here, the age cohort, men and women in the third column. So we can after analyzing that table, we can identify that prevalence of cardiovascular disease increases progressively with age, exceeding 80% in both men and women greater than 80 years old. Next slide, please. Okay. Principal effect of aging on the cardiovascular system. So in the first slide, we're gonna talk about increased arterial stiffness that accompany the age effect. So with the aging, all the artery became more stiff. This will lead to increased afterload and increased systolic blood pressure. Decrease the myocardial relaxation and compliance, which lead to increase the risk of diastolic heart failure and atrial fibrillation. Impaired responsiveness to beta adrenergic stimulation. This will lead to decreased maximum heart rate and cardiac output, impaired thermoregulation. With the age and with the aging process, we're going to have a decrease in sinus node function and conduction velocity in the atrioventricular node and the infranodal conduction system. This will lead to higher risk of sick sinus syndrome, atrioventricular block, left anterior fascicular block, and bundle branch block. Next slide, please. Next slide. Yeah, thank you. No, can you go to the previous slide? I still have the second slide from effect of aging. So there is a table, there is two tables, Yes, thank you. So also we're going to have an impaired endothelium-dependent vasodilation. This will lead to increased demand ischemia and the risk of coronary artery disease and peripheral artery disease. Decreased baroreceptive responsiveness. This leads to higher risk of orthostatic hypotension, falls, and syncope. Decreased exercise response lead to decreased maximal heart rate, maximal cardiac output, VO, oxygen maximum, and coronary blood flow, peripheral vasodilation. And this will also result into decreased exercise capacity, increased cardiac complication like ischemia, heart failure, shock, arrhythmia, death with illnesses. Next slide, please. Okay. So clinical effects of the cardiovascular changes. So in healthy older adults, age-related changes have modest clinically relevant effect on the cardiac hemodynamic and performance at rest. A resting heart rate, ejection fraction, stroke volume, and cardiac output are well preserved even at a very advanced age. Ability to respond to increased demand associated with exercise or illnesses declines progressively with advancing age. So the peak aerobic capacity declines inexorably with age. Next slide, please. Okay, so what are the risk factors for cardiovascular disease? So we have 4 major modifiable risk factors: hypertension, diabetes mellitus, dyslipidemia, and smoking. Higher rate for cardiovascular disease in older people. It's an absolute number of cases for risk factors tend to increase with the age. Multiple risk factors act in concert with the age-related cardiovascular changes to promote the development and the progression of heart and vascular disorder. Next slide, please. So first, the hypertension. Pulse pressure. The pulse pressure, which is defined as the difference between systolic and diastolic blood pressure, increases with the age. So isolated systolic hypertension becomes the dominant form of hypertension in older adults. The SPRINT trial demonstrated a reduction in the risk of major adverse cardiovascular event and all causes of mortality, with more intensive systolic blood pressure lowering in a patient at increased cardiovascular risk, particularly those who are 75 years and older. Next slide. Diabetes mellitus. So as in younger patients, the impact of diabetes confers as a significant risk of cardiovascular disease in older patients, approximately doubling the general risk. In the Framingham Heart Study, the excess risk associated with diabetes was greater in both men and women 65 years old than in younger individuals. Despite the risk, so the AGS has recommended that for older adults with multiple chronic condition, ADL impairment or cognitive impairment, more lenient hemoglobin A1C target, example less than 8%, are reasonable given limited life expectancy and the risk of hypoglycemia with overly aggressive therapies. Next slide. I think it's Dr. Riham's I will give the floor to Dr. Riham to continue presenting the risk factor.
Okay. Thank you, Dr. Zhor. Thank you for your presentation. Thank you, Dr. Yassein. I'm going to continue cardiovascular presentation. I will talk about the rest of the risk factors and about acute coronary syndrome. Okay, dyslipidemia as a risk factor. The strength of the association between total cholesterol and LDLD is low in elderly. Okay, and incidentally with age, especially after 8 years, it declines. The most important risk factor is low HDL cholesterol levels and high ratio of total cholesterol to HDL. Okay, they are independently associated with coronary events among adults at least up to age 85. So for elderly, a low HDL is more important than a high LDL. And clinical trials have demonstrated benefits of statin therapy in moderate and high-risk patients up to 85 years of age. Next slide, please. Okay, the fourth risk factor is smoking. In general, smoking prevalence declines with age, partially due to successful smoking cessation and due to premature deaths in smokers. But among older smokers, smoking cessation is associated with substantial reduction in cardiovascular risk. In most studies, smoking remains a strong and independent risk factor for cardiovascular events among older adults. So smoking in general, it has a lower prevalence, but yet smokers who are elderly, they still have a high risk for CPD. There are some other additional risk factors, like low level of physical activity. It was associated with cardiovascular disease and all-cause mortality in old ages, and frailty, which means like having a poor physical fitness, is also associated with the increased risk of development of cardiovascular disease and mortality after MI. Regarding obesity and coronary artery calcium content on CT, the risk, whether they are important risk factors or not, it's still unclear in older adults. Next, please. Okay, in general, mortality after acute MI increases with age. And prevalence of clinical coronary artery disease increases with age in both men and women. Like we said, the older you get, the more risk you have for coronary artery disease. Incidence of angina pectoris peaks between the age of 65 and 84. And after the 84 years, it decreases. Okay, 2/3 of all MIs, excluding silent MIs, occur in adults more than 65 years old. Next, please. Okay, now we're going to talk about acute coronary syndrome. Acute coronary syndrome encompasses unstable angina, non-ST elevation MI, and ST elevation MI. Okay, unstable angina or non-STEMI, they are often considered together because they are pathophysiologically similar, and they're clinically they are difficult to distinguish, and they also have the same management. The way that we can differentiate between unstable angina and non-STEMI is by measuring the cardiac biomarkers, measuring cardiac troponin. Cardiac troponin is elevated in non-STEMI, and in unstable angina it is normal. Okay, and both of them, all of them, they present with chest pain. Okay, how do we differentiate between unstable angina and stable angina? Unstable angina, it occurs, chest pain occurs at rest, while stable angina with exertion. Okay, moving forward, please. Okay, the proportion of patients who present with chest pain declines with age. Yes, for elderly, they always present with atypical angina. They don't present with the typical chest pain that is substernal, crushing, radiating to the jaw. No, the most common presentation is shortness of breath. So they could present with shortness of breath, nausea, and vomiting. Sometimes they present with epigastric pain. So it is very important to have a high degree of suspicion. So this atypical presentation results in delay in diagnostic tests and delay in initiation of treatment. Next, please. Okay, any patient who is suspected with acute coronary syndrome should receive aspirin as a first step, 160 to 325 milligram, regardless of age. Also, should receive oxygen if their oxygen saturation is less than 92%. And then they should receive nitroglycerin, either IV or sublingual. Unless there is right ventricular infarction. In right ventricular infarction, nitroglycerin is contraindicated because it decreases the preload. In right ventricular infarction, we need to increase the preload by giving IV fluids and so on. So just be sure that it's not right ventricular failure before giving nitrates. And then we give IV morphine. Okay, we give IV morphine. Morphine, it reduces the pain, and by reducing the pain, you reduce the sympathetic stimulation, and you put the patient at ease. You give morphine if nitroglycerin is ineffective in relieving the symptoms. Please, next slide. Okay, class 1 recommendations for antithrombotic therapy for patients for SAS, in addition to aspirin. So we give aspirin plus P2Y12 inhibitors, which are clopidogrel or ticagrelor. Usually, or you can give aspirin with anticoagulant. So you have two options, either aspirin with clopidogrel or aspirin with anticoagulant. Anticoagulants we use are enoxaparin, which is heparin enoxaparin, or unfractionated heparin, or bivalirudin, or fondaparinux. Okay, for prasugrel and glycoprotein 2B3A inhibitors, they are generally not recommended for ACS because prasugrel has been associated with increased bleeding risk. Next, please. Okay, the most important step in management of acute coronary syndrome is reperfusion. Especially in STEMI, it has to be done 90 to 120 minutes since arrival from the hospital. Okay, for non-STEMI and stable angina, it can be I think in the first 24 hours, but still reperfusion therapy is the most important part of the management. Type we can do reperfusion either by percutaneous coronary intervention or fibrinolytic agents, and PCI is always recommended, or it is preferred over a fibrinolytic agent. Okay, which should be done within 12 hours of onset of STEMI, or within 24 hours if there are signs of symptoms of ongoing ischemia. If the patient symptoms of ischemia are ongoing, you can give it within 24 hours. Okay, reperfusion therapy has a risk of intracranial hemorrhage, and this risk fibrinolytic agent, they have a risk of intracranial hemorrhage, and this risk increases with age, especially after age 75. And this is higher with fibrin selective agents like TPA or reticulase, and lower with streptokinase. Okay, PCI is the preferred reperfusion strategy. Like we said, it has been associated with superior outcomes relative to fibrinolysis. It should be done within 120 minutes. Actually, if there is PCI available in the hospital, it should be done within 90 minutes. If it's not available in the hospital, it should be transferred into another hospital within 120 minutes. If not, if it is not available within this time, you give fibrinolytic. Okay, after documented ACS, patients should be maintained on aspirin. So this is the acute management that we talked about: reperfusion, aspirin, clopidogrel, morphine, oxygen. After it, we maintain the patient on aspirin, beta blocker, or ACI, and statin. In the absence of contraindication, he takes those for life. And we give statin even in the absence of hyperlipidemia. So statin here is not due to hyperlipidemia. They say that the statin stabilizes the atherosclerotic thrombus. And in addition to that, we give clopidogrel or ticagrelor or prasugrel for 1 year, whether or not PCI is performed. And whenever it's feasible, refer the patient to structured cardiac rehabilitation program. Isn't the nebulization, say, Zhor to balloon time? Yes, if the PCI is available in your hospital, it should be done by 90 minutes. If not, and you can refer him to a hospital within 120 minutes, you do that referral. If all of this is not available, you do fibrinolytic. Okay, Dr. Sabri? Okay, thank you, everybody. Now my colleague will continue the rest of the presentation.
Okay, Assalamu alaikum, everyone. Thank you, Dr. Riham. First, I would like to introduce myself. My name is Salish. I'm a medical graduate from National Ribat University, since it's my first time presenting today, and I'm going to continue talking about chronic coronary artery disease. So, in older patients, symptoms of coronary artery disease often differ from younger individuals. Rather than experiencing typical chest pain, older patients frequently report exertional fatigue or shortness of breath. This divergence is largely attributed to the older population having more extensive and severe coronary artery disease, including higher rates of triple fissile and left main involvement. Additionally, they commonly have a history of prior MIs and associated left ventricular dysfunction. So this highlights the complex nature of their cardiovascular conditions. We're gonna move to diagnosis of coronary artery disease, chronic coronary artery disease. So in clinical practice, diagnosing coronary artery disease poses a distinct challenges across different age groups. Notably, while the symptoms of coronary artery disease may present similarly in both age groups, older adults typically exhibit a higher likelihood of having significant coronary artery blockage prior to testing. This higher pretest probability in older adults often results in lower rates of false positive results from stress tests, which are commonly used in initial diagnosis tests. However, paradoxically, older adults also tend to experience higher rates of false negative results from these tests. So, given these considerations, stress testing remains the preferred initial diagnostic tool for most patients presenting with stable symptoms suggestive of coronary ischemia. This approach allows clinicians to assess cardiac function and ischemic response efficiently, despite the announced challenges posed by age-related differences in disease prevalence and test accuracy. We should also know that diminished exercise capacity can contribute to higher false negative rates on exercise test, but not with the pharmacological stress test in older populations. Now we're going to talk about the control of risk factors. So to mitigate the progression of coronary artery disease, effective management of risk factors is crucial. So we have some points. First, we need to emphasize the importance of cessation of tobacco products as priority due to their detrimental impact on cardiovascular health. Second, we prescribe a diet low in saturated fats and cholesterol while promoting high consumption of fruits, vegetables, and whole grains, such with the Mediterranean diet. So this diet approach is known to support heart health through its nutrient-rich components. Additionally, encouraging regular aerobic exercise, such as brisk walking for at least 30 minutes on at least 5 days per week. This regime enhances cardiovascular fitness and overall health. Lastly, we can also recommend a modest weight reduction, particularly for individuals with body mass index of 35 or higher. This measure helps alleviate the strain on the heart and lower risk factors associated with disease progression. So implementing these strategies effectively address key risk factors associated with coronary artery disease, thereby supporting optimal cardiovascular health and reducing disease progression. Now we're going to talk about the medical therapy. So medical therapy for chronic coronary artery disease focuses on several key interventions to reduce cardiovascular risks and improve the outcomes. First, all patients with coronary artery disease should receive low-dose aspirin to prevent thrombotic events. The dose from 75 to 162 milligrams per deciliter milligrams daily, sorry. Second, statins are also recommended for all patients regardless of the LDL cholesterol levels. So statins significantly reduce the mortality and major cardiac events. Current guidelines suggest using moderate to high intensity statins, an example, atorvastatin 40 to 80 or rosuvastatin 20 to 40 milligrams. ACE inhibitors are also beneficial in reducing mortality and cardiovascular morbidity in coronary artery disease patients, especially those with hypertension, diabetes, reduced left ventricular ejection fraction, less than 40, or chronic kidney disease. Beta blockers are recommended for at least 3 years post-MI, unless there's an obvious contraindication, because beta blockers like metoprolol, carvedilol, and bisoprolol are crucial for improving survival and managing angina symptoms in coronary artery disease patients, particularly those with reduced left ventricular ejection fraction. So as for calcium channel blockers, they're effective as anti-ischemic agents. They're used when beta blockers are contraindicated or in combination therapy with beta blockers or long-acting nitrates. Also speaking about long-acting nitrates, isosorbide mononitrates is less effective than beta blockers or calcium channel blockers for anti-ischemic treatment, but may be used as combination therapy. Lastly, we have ranolazine, which is used alone or with conventional anti-angina medications. Ranolazine helps reduce angina and improve exercise tolerance in symptomatic coronary artery disease patients. So these therapies aim to manage symptoms, prevent cardiovascular events, and improve quality of life in patients with chronic coronary artery disease, guided by individualized risk assessment and treatment goals. Now moving on to revascularization therapy. So in patients with chronic coronary artery disease, coronary revascularization procedures such as percutaneous coronary intervention or bypass grafting are primarily indicated for two main reasons: symptoms relief and mortality reduction. First, when symptoms persist despite optimal medical therapy, revascularization aims to alleviate angina and improve quality of life. Secondly, revascularization may be considered to reduce mortality in specific high-risk patient groups, particularly those with severe coronary artery disease or ischemic cardiomyopathy characterized by reduced left ventricular ejection fraction. So it's important to note that as patients age, especially those over 8 years old, the risk associated with both BCI and bypass procedures increases, including higher rates of complications and mortality. Therefore, decision-making regarding revascularization in older adults requires careful consideration of individuals' health status, comorbidities, and expected benefits relative to the risks. Ultimately, the choice between BCI and bypass depends on factors such as extent and location of coronary artery disease, overall health status, and patient preferences, aiming to achieve optimal outcomes in symptoms management, mortality reduction for patients with chronic coronary artery disease. Moving on to the comparison between PCI and the bypass surgery. So when we compare PCI with the bypass surgery for coronary artery disease, first talking about long-term outcomes, they're generally similar between BCI and bypass in terms of survival and prevention of major cardiac events. But in short term, PCI has lower short-term mortality and fewer major complications compared to bypass procedure, including less cognitive dysfunction. However, bypass is associated with longer hospital stays and recovery times. Also, PCI may require more subsequent revascularization procedures over time compared to bypass procedure. And late mortality rates can also be higher with PCI. Additionally, in patients with diabetes, extensive coronary artery disease involving multiple vessels, or left main disease, bypass often provides superior outcomes compared to PCI or medical therapy alone. Moving on to the risks of bypass surgery. So up to 50% of older patients undergoing bypass with extracorporeal circulation may experience measurable cognitive decline post-surgery. So must recover with 3 to 6 months, but small percentage may have persistent issues. So post-surgical functional decline is common and can sometimes be irreversible. So early rehabilitation during hospitalization and structured cardiac rehabilitation often after discharge are crucial for mitigate these defects. So in summary, the choice between PCI and bypass depends on the factors such as extent of coronary disease, patient characteristics, and preferences. While PCI offers advantage in short term, bypass grafting may be preferable in certain high-risk patient groups due to potentially better long-term outcomes and low-risk subsequent procedures. Careful consideration of these factors is essential in optimizing treatment decisions for patients with coronary artery disease. So, in conclusion, as individuals age, significant changes occur in the cardiovascular system that affect their health outcomes. Aging is characterized by gradual reduction in cardiovascular reserve capacity, impacting the heart's ability to respond to stress and maintain optimal function. Also, older individuals Can you hear me?
Yes, we can.
Okay. So also older adults with cardiovascular diseases often present with different symptoms and may respond differently to treatment compared to younger patients. So this necessitates tailored approach in diagnosing and management of these patients. The majority of acute coronary syndrome, hospitalization, and a significant proportions of acute coronary syndrome related deaths occur in patients aged 65 and older. So this age group faces higher risk of adverse outcomes due to age-related physiological changes and comorbidities. Also, while current treatment of acute coronary syndrome offers similar benefits across age groups, older patients are at increased risk of experiencing major complications from therapeutic intervention, requiring careful consideration of risk versus benefits in treatment decisions. So understanding these age-related cardiovascular changes and associated risk factors is crucial for delivering effective care and optimizing outcomes in older adults with cardiovascular disease. Thank you.
Thank you so much for great presentations. Thank you for all the presenters. Great job. Any questions? Thank you once again.
Okay, thank you, Dr. Saleh, Dr. Zhor, and Dr. Riham for the presentation. If there is no question, we can go and I think to next presentation. Can we proceed, Dr. Nader?
Yes.
Okay, so our next presentation will be a highlight about the pathway application for the ACPG certification. And I'm going to have my colleague, Dr. Mohamed, who will be speaking about that. Dr. Mohamed, if you're here, you can share your screen, please.
Hello. Good afternoon, evening, everyone. Can you guys hear me?
Yes.
All right. Hello. Greetings, everyone. I'll introduce myself again. My name is Dr. Mohamed Atif Mohamed Yusuf. I am also, just like Dr. Yassein, a graduate of University of Jazeera, batch 2021. Actually, I'm from the red team, but I was honored by Dr. Yassein and also Dr. Mizoni to have the opportunity to share my presentation with the Lime team today, and which is going to be about Pathway 6 for ECFMG certification. All right, I'll just share my screen right now. Can you, Yassein, can you make me share my screen?
You can go now.
All right, is it clear for everyone?
Not yet.
It's loading, yeah. Just a couple of seconds.
What about now?
Yes.
Great, excellent. So in today's presentation, I'm going to be talking about Pathway 6 of the ECFMG certification. So let's just hop into that. First of all, I'm going to talk about the ECFMG pathways in general. What are these? So basically, ECFMG pathways are pathways that are developed to ensure that international medical graduates possess the necessary qualifications and clinical skills to practice medicine in the United States. Basically, this is just like their way of confirming that you're eligible to practice in the United States. And how do they do that? Through the pathways. So these pathways are particularly important given the suspense of the previously known USMLE Step 2 clinical skills. So previously, I believe, about 4 years ago, before the COVID-19 incident, the alternative or the main way to be ECFMG certified is to complete your exams in addition to partake in what is called USMLE Step 2 CS exam. So this has been replaced by the pathways mainly. And also the ECFMG pathways provide alternative means for IMGs to demonstrate their readiness for medical licensure and residency programs in the US. So what are the pathways? We got 6 different pathways. We got pathway 1 to 6. So pathway 1 is for people who are already licensed to practice medicine in another country. Pathway 2 is medical school accredited by a agency recognized world federation, WFME. Pathway 3 is medical school accredited by agency recognized by National Committee, NCFMEA. We got Pathway 4. I think I've mixed up Pathway 2 and 3, but if I'm not sure, wait a minute. So Pathway 4 is for graduates of medical school with medical education programs that meet ECFMG requirements for clinical skills. Pathway 5 is for license to practice medicine in another country and recognized as equivalent for their standards. And lastly is Pathway 6 is evaluation of clinical patient care skills by licensed physicians, which we are going to be talking about today. So the Pathway 6 is this pathway addressed for the need for comprehensive clinical evaluation, ensuring that IMGs are well prepared for the US health system in general. And it explores all the aspects of the applicant, if he is eligible or not to undertake or to be ECMG certified through this pathway by simply testing his clinical sets, or like by set of clinical scenarios that you should be doing, which is what you're going to be tested on. And so basically, who is pathway 6 for? Wait a minute, I just gotta adjust something. Sorry about that. There we go, perfect. All right, so who is pathway 6 for? Basically, what you need to know is that pathway 6 is for applicants who do not meet criteria for other pathways. If you're not eligible for pathway 1, you don't have any licensure, or you're not licensed in any country, you're not eligible for pathway 1. If you're not eligible for pathway 3, you're not a recent graduate from a WFME certified or accredited university, then you may apply for pathway 6. Because usually in our scenario for us IMGs, it's either you're applying through pathway 1 or pathway 3, I believe. And if you're not eligible for either, you can just partake in pathway 6. So what do you need for pathway 6? What are the requirements for pathway 6? Basically, obviously, your medical school should be accredited. Also, you need to have finished your step 1 and step 2 CK examination. You need to have your OATs passed within the minimum requirements. And also, last but not least, is to finish or partake in the mini CEX examination. So our main focus today is going to be on the mini CEX examination, since the other requirements are pretty much also required in the other pathways. So I'm going to explain what the mini CEX exam is about. So basically, the mini CEX examination is a well-studied workplace-based assessment tool used to evaluate an individual's clinical skills in a variety of clinical settings. Well, it says well studied because there have been actually a research about it. I believe multiple researches about the validity of a mini CX exam, and I believe I have a paper on that I can pull. Can you give me a minute? So I'm just gonna share the link for that, so you guys can just check it out later. All right, so it's a well-studied workplace-based assessment tool that you use to evaluate an individual's clinical skills in a variety of clinical settings. So basically, ECFMG's mini CX examination is you're going to have different physicians evaluating you on a set of certain standards that are required for ECFMG. It's pretty much like a checklist provided by ECFMG that you're going to have your mentors, tutors, you're going to have physicians that just are going to evaluate you based on certain clinical skills. Of course, these encounters are real in-person clinical encounters. So how many of the encounters should it be? It's 6 encounters, and each doctor is allowed maximum 2 encounters. So 2 encounters per doctor. So you can have 3 doctors evaluating you for 2 encounters, or you can have 6 doctors each evaluating you for 1 encounter. So what are the criteria for acceptance, like acceptable physicians or acceptable evaluators? Like, how do I know that my evaluators are valid to evaluate me, or what is the accepted criteria? So first of all, they gotta agree to directly observe you and evaluate you. They should, or they must currently hold a full unrestricted license to practice medicine without supervision in the jurisdiction where the clinic encounter will take. And also, this unrestricted license to practice medicine should be up for a minimum of 5 years. So basically, you're gonna have to look for physicians or mentors that you know who are at least fully licensed, unrestricted, working without supervision for a minimum of 5 years. Of course, they gotta give you their approval for them to share their names and email addresses with you and with ECFMG. They should not be your relatives, and it not to be compensated by you to perform the evaluation, nor to be compensated by any third party to perform the evaluation. So basically, to sum it up, they should have a full unrestricted license for at least 5 years. They gotta agree to evaluate you. They gotta give you their names and emails, not be your relatives, and not to be compensated by any sort of incentives. So you will be required to attest that each physician evaluator meets these criteria at the time you submit the physician's information to ECFMG. It is your responsibility to ensure that all of your physician evaluators meet ECFMG's criteria. Since you're going to be like the moderator of this entire process, you're going to keep an eye on your doctors. You're basically going to send them emails or like contact them, informing them that you need to have their full names, of course, their emails, for them to be evaluating you. And then you're going to partake in the encounters. So before we talk about that, we're just going to talk about what is being assessed in the mini CEX exam. So you got pretty much 4 main points in the mini CEX exam. It's medical interviewing skills, physical examination skills, professionalism, communication skills, clinical reasoning, and judgment. So I believe I have a PDF of the just a second. So this is what it looks like. This is a mini CX form. So basically, you're gonna, or not you, like your physician is gonna, for your name, is gonna put his name, the encounter date, where did this setting partake? Is it the outpatient, inpatient, emergency department? The facility name, obviously, in which the doctor have, in which his license is, like, this is his jurisdiction. The facility, city, country, patient, age, and gender only. So this is like the 4 sets. You have medical interview skills, physical examinations, professionalism, communication skills, clinical reasoning, and judgment. So basically, the scale is 1 through 9. So 1 to 3 is that you're performing at the level of medical school. 4 to 6 is performing at the level of a medical grad. And 7 to 9 being the fact that you're at the level of an experienced doctor or practicing physician. So these different aspects, you're gonna partake in the MCX exam. The doctor or your doctor is gonna be having, is gonna give you an encounter. Let's say 2 encounters, 2 cases. He's gonna evaluate you. And on each of the 4 aspects, he's just gonna rate you from 1 to 9. So what is the minimum needed to what is the minimum accepted by ECFMG? It's going to be 4 to 6, at least 4 at the level of a medical grad. So this is what I expected. So basically scoring in the mini CX exam after, so before that, let me just talk about, because I'm not mentioning this in the PowerPoint. So basically after getting, after starting your application for the ECFMG certificate, you're going to select Pathway 6, obviously. And after completing everything, you're just writing your name and paying the fee, I believe. You're gonna have your own dashboard, which you're gonna have your own, I forgot the name. It's like certain dashboard for the MECX exam. So when you press that, you're gonna be asked to add encounters. So when you're adding encounters, you're gonna be asked to give full name of the doctor, his full name, correct full name, and his email. So after you do that, let's say you're doing 2 encounters for one doctor. You're just gonna do 2, and an email is gonna be received by your doctor. So after your doctor received the email, he's gonna basically receive a link that he should basically like open a certain portal, which where he's gonna access his profile and he's gonna update his information. He's gonna provide his name, his date of birth, his registration number, his the setting where he's practicing right now. You're gonna provide all that, or he's gonna provide all that. Then after that, he's gonna go to his dashboard where he's gonna find 2 of the requests that you have sent to him. So after he accepts the request, only then you could partake in the mini CX exam or like have the real life encounters. So after you do that, he's gonna go through the things we're talking about here, the aspects of the mini CX, the medical interviewing, physical exam, professionalism, plagiarism. He's gonna rate you. He's gonna put all the information, just as we talked about previously. And then after that, he's gonna submit it. So after it being submitted, then his job is done. You should thank him and check your dashboard. You're gonna find that your mini CX exam is done. And you should do that for 6 encounters, in which afterwards you're done with the part of the mini CX exam. I hope we're all on the same page here. So scoring in the mini CX exam or mini CX evaluation after ECFMG receives all the 6 completed mini CX evaluations for your application, ECFMG will determine your score in each of the 4 components evaluated. If you do not meet ECFMG scoring requirements and for the mini CX evaluations will automatically be provided to the Pathway 6 review committee for review. If the decision of the committee is that you have not met the requirements, you will be able to request a recheck of your mini CX scores. Instructions will be provided to you if applicable. So basically, after you're done with your 6 encounters, you're going to send it and they're going to be evaluated. And they're going to be validated whether they're true, like you have met their standards or not. If you have any sort of complaints or if you have not met any certain requirements and you would like to request a recheck, you can also do that. I should also note that after sending your doctor an email or a request for an encounter, you'll need to have finished that within 15 days. Otherwise, the encounter or the request is just gonna automatically just cancel itself. Can you resend the encounter again? Yes, of course you can, but you should at least finish the encounter within 15 days, like each encounter, not like the whole mini CX. Right, so before summing up everything, I'm just gonna mention some frequently asked questions about this pathway. So are the doctors evaluating you supposed to be US-based or US-based physicians? No, don't have to be US-based physicians. Any doctor that have met their criteria for at least being 5 years licensed, obviously unauthorized or not unauthorized, like 5 years on. I mean, I'm just forgetting words at this point. So basically, licensed, unrestricted license to practice medicine without supervision for a minimum of 5 years. If anyone is just meeting these criteria right here that I mentioned, you should be good to go. They don't have to be US based, although they have to be in residing in where you live. Otherwise, how are you going to be able to do your encounter? Sorry about that. Let me just pull it again. All right, so that is for question number 1. So question number 2, how long did it take to complete the MediCX exam? If you're like, you can literally finish the CX exam within the same day. If you're done with your examination, if you're done with the encounters, like let's say you know the 3 doctors and they all agreed to do the encounters on the same day, and you provided them with the emails and they responded quickly and they did your evaluation like on the dot, you're literally going to finish the CX exam on the same day. So what is the fee for the mini CX exam? So it doesn't have a certain fee since it's all like included in the ACFMG certificate fee, which is, I believe, $25. So it's the same. Like whether you're applying for pathway 1 or pathway 6, you're gonna pay $925, and then you're gonna do the mini CX exam. Like there are no additional fees. How long would it take after submitting to mini CX exam? So I believe it's about like 2 to 3, maybe 4 business days. They're gonna validate your mini CX exam, and then they're gonna. And then obviously you can proceed with if you have the other requirements met, like the OET, the step 2, step 1. If you have them ready, you can just submit it. Can you do that? Can you do the MediCX exam before doing step 1, before doing your OET exam? Yes, absolutely, you can do it. As a matter of fact, it's actually the first step that you should do. You could just get done with your MediCX exam and just have it ready, and then you can wait for your OET score or like step scores or whatever, and it should be fine. So how many doctors can evaluate me? Just so as I mentioned, it is 2 encounters per doctor max, so at least 3 and maximum 6. So what is the minimum required to pass in the MediCX exam? So as I mentioned, it should be at the medical graduate level, which is 4 at least. Let me pull it up again. So it's at least 4 level of medical graduate on each of the 4 aspects of the MediCX exam. So I believe this is everything. To sum up what I said, ECFMG Part 6, or Pathway 6, so you need to be accredited, step 1, step 2, OET, you're doing the MediCX exam, 6 encounters, at least 5 years, unrestricted license, not compensated, not your relative, 4 aspects of the exam, at least medical graduate level, and you're good to go. Thank you everyone for watching me, and we'll be taking questions if anyone has.
Thank you so much. This great presentation, Dr. Sabri. If you have question or comments, go ahead.
Yes, thank you, Dr. Nader. Thank you, Dr. Mohamed Atif, for this great presentation. So actually, I have 2 questions. The first one is that do you have like any resources for preparing for the mini clinical
Sorry, Dr.
examination?
Sabri, sorry for the interruptions. Can you just check your mic? I can't hear you well.
All right.
What about now? Is it clear?
Yeah, way better. Thank you.
All right. So thank you very much for this great presentation. I have two questions. The first one is that is there any resource for the mini clinical examination for preparing? And the second question is that actually about the result. Like, I receive the result or scoring from the ECFMG, or they just will let me know if I get certified or not?
All right, thank you for your questions. That's a very good question. The first question was that how do you prepare for the mini CX exam? So basically, this is not like a specific, like sort of a exam that you should have like certain materials to study for. It just basically like measures your own clinical knowledge and like clinical like reasoning, the ability to do a physical exam. And it basically just depends on your physicians, I believe. You're gonna just tell them that I need to have these 6 encounters. And I guess it all depends on the person who's examining you, because he might be all right. I need you to give me a full history, full examination. Maybe like give me what are you gonna do? Maybe he's gonna do something like brief, like give me a brief history, brief examination. The thing that is supposed to be like what are they trying to do is like they just want to see how well you're gonna be doing. Like, are you sufficient to do your like, can you take your history right? Can you do your examination right? Can you come close to the like differential diagnosis, or like give a spot on the diagnosis? Can you recommend some further management and investigation? Basically, this is the sum up of your colleague experience and your medical life so far. Like there is no certain like way you could, like there's no certain like content that you should be revising for. It's just that you as overall, like as a doctor. So the second question, I believe, was you said, can you repeat the second question, please?
Yeah, thank you for answering the first one. The second is that what about the results? Like, do I receive the result through my email or?
Right. Yeah. Okay. So about the results, so basically, after, just like I said, after you submit your pathways, which is literally the first step that you're gonna do. So after you submit it, you're gonna be contacted after a few days. I mean, like 3 to 4 business days. I'm not sure actually. You're gonna be contacted that your mini CX exam is now approved. Then you're gonna go onto the next step, which is like validating your step scores, your OET scores, and then you're gonna wait for your ECFMG. So basically, for the ECFMG process itself, like after completing all the requirements, after you upload it, you're gonna be they're gonna first validate your requirements. They're gonna be like, okay, we have checked everything. And then it's gonna be like 10 days, I believe, maybe 10 business days for you to be ECFMG certified on the Oasis portal. And I believe like 14 days are gonna receive the actual certificate. Like they're gonna mail it for you in 14 days, I believe.
Okay, thank you very much.
You're welcome. Dr. Ahmed Dirar.
Thank you, Dr. Mohamed, for your great presentation.
You're welcome. Go ahead.
Is it okay to be a registrar, the one who can evaluate me in the mini 6 exam?
Sorry, can you repeat that? I didn't get that.
Is it okay to be a registrar, like the one who can evaluate me in the mini 6 exam?
Oh, like a registrar is like a resident here, so you mean, right? I don't think so, because like residents are they're supervised mainly, so they should be, so they're out of the question. So they should be either attendings or, so basically they have to be like fully like at least unsupervised for at least 5 years, and residents are practically being supervised by their attending, so you cannot have your
Like,
registered.
okay, general practitioner, is it okay?
Yeah. Oh, yeah. That's another question that I didn't put in the frequently asked questions. Does it have to be a specialized doctor? Like there's certain specialties, different specialties. General practitioner, no, it doesn't matter. You just have to be, even GPs can evaluate you. Just at least 5 years unsupervised license. That's it.
Okay, thank you so much, Dr. Mohamed.
All right. Thank you so much. All right. Any other questions?
I can see some co culture in the chat box if you can go through that as well.
All right. Okay. So do the physicians need to be from the same country? I mean, obviously, if you're talking like nationality wise, no. But like if you're talking about whether they have to be in the same place, I mean, unless you can like unless you're gonna be in like 3 different countries for the whole process, then no, they need to be in the same country, because otherwise you're gonna write your encounter. Like let's say, for example, I did my encounter here in Sultan Qaboos hospital in Salalah. My doctor is also working in this hospital, so I reached out to him and I told him about the BCX exam, and I did it with him. So it doesn't matter where it is, but you should be present live, because you're going to be evaluated live. That's basically the gist of it. All right. So any further questions? Please do not hesitate to question. All right. If there's not going to be any other questions, I would like to thank the red team and the line team, Dr. Yassein, Dr. Mizuni, and of course, Dr. Nader, for giving us the opportunity to present this presentation. I hope I was helpful and to give a little back to the community. And thank you guys so much, and have a good day.
Okay, thank you so much, Dr. Mohamed, for sharing your thoughts and for sharing your experience. Okay, the next presentation is about the Microsoft Coach tool, and I'll be presenting that. So it will not take a lot of time. I'll just start sharing my screen, maybe a couple of minutes, like 10 minutes, and I hope we got use of that. Let me share my screen. Dr. Nader, if you can assign me the host again. Okay, thank you so much. Can you all see my screen now?
Yes, it is quite clear.
Okay, good. So again, my name is Yassein Elhussein. I'm a graduate of University of TGRF, and today I'm going to be presenting about the Microsoft Rehearsal Coach tool. I have no disclaimer to declare, other than that I'm using AI to generate some of the illustrations on the PowerPoint. So the content, I'm just going to give you introduction about the PowerPoint or the Coach tool in the Microsoft PowerPoint application, and the benefits of using the rehearsal tool. And I will walk you through step-by-step tutorial and live demonstration on how to do that. At the end, we'll have a question and answer as well. So Microsoft PowerPoint Rehearsal or Coach tool is a feature in the Microsoft PowerPoint that helps us to practice how to present. So it's a tool it's literally like an AI coach that will help us on enhancing our presentation skills, and by providing like real-time feedback analysis for your performance and presentation, like giving comments on how you pace your speech, how you say the words, how you pronounce, how you use different vocabulary words. And so it's generally used to improve and to practice and to rehearse before going into presentation. So the purpose mainly is to improve your presentation skills and build up some confidence. So why do we need to use the coach tool? As I said, we as medical professionals, we need to present sometime. We daily present, we communicate with the patients. So it's really helping enhancing the communication skills and the presentation skills. So you might present the case in attending physicians, you might present a case in conference or poster presentations or oral presentations or facilitated workshops. So generally we need an eye on us to give us a feedback so that we can improve ourselves and enhance our skills. So, but speaking about the Microsoft Coach tool, it focuses mainly on 4 areas, like it helps you to improve and maintain an appropriate speed and rhythm for your speech, and it enhance the clarity. It will give alerts into if you're using filler words or complex phrases, like if you're using all, you have like unnecessary pauses that will be detected as well to be analyzed. You get feedback real time, so you can improve and take an action while you're presenting and while you're rehearsing as well. It will definitely boost your confidence as practice makes everything perfect. So you build your confidence throughout repetition. So it's just having someone giving you feedback at your own free time. So that helped really to boost your confidence and to have a good presentation skills. The good thing about the tool is that it gives a real-time constructive feedback, like actionable feedback that you can help you to refine your presentation skills and to improve yourself. Step by step, you just have to open your PowerPoint presentation. You have to navigate to the toolbar, searching for the slideshow, and then you have to tap on the slideshow and click, and then you will find Rehearse with Coach. Click on that. Then on the right bottom, on the right of the screen, you can click on Start Rehearsing, and then that's it. Go and speak naturally, present your presentation. Try to be like realistic. Try to be yourself. Try to present and deliver everything like you're presenting to a large audience. So at least you have real, realistic feedback. And then you can monitor the feedback and the analysis. Also on the bottom of the screen, you have you will receive a real-time feedback on the screen where you can act accordingly to improve and enhance your skills. So that's it. It's just basically AI tool through the Microsoft PowerPoint application, online or offline. You can use both. It gives feedback. And I think now we're ready to start live demonstration, how that works. I'll stop sharing my screen. I'm going to another presentation where we can start doing that. Okay, can you see my screen now?
Yes, very clear.
And it shows the clinical examination slide, right?
Yep.
Okay, so this is Microsoft PowerPoint online on Microsoft 365. And just I open my presentation. That's home. You have to go to the slideshow. And then after going to the slideshow, you can see the Rehearse with Coach. Click on the Rehearse with Coach, and then you can even enable the body language where you have also a real feedback on your body language. I have like video camera. I'm gonna click on that, and then I'll just click on Rehearse with Coach. Can you see my screen now?
All good.
Okay.
Yes.
Okay, no camera access. Let me close and rehearse without camera. Okay. Okay. So today I'm going to present, you see, so I detect filler words. Okay, I'm going to present anyway, and at the end we're going to have an analysis. Try to speak a little faster. Okay, today I'm presenting slides about clinical examination. So as you all know that the clinical examination is a part of the approach that we approach the patient to reach out to clinical diagnosis. So we use clinical history taking and then clinical examination and then some workup on differential to list of differential diagnosis and to perform some investigations to reach out to a possible clinical diagnosis and then to confirm the diagnosis and start a plan of management. Speak a little bit slower. Okay, so yeah, approach to the patient. First of all, you have to introduce yourself. Like, I'm Dr. blah, blah, blah. I'm the doctor working in the hospital today. I'm the doctor in charge of the case today. I'm the doctor of the clinic today. I would like to confirm your, see, try to not use too many filler words like, Okay, I would like to confirm your name and age, please. Okay, my name is blah, 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 and I'm 37 years old. Okay. Then you have to explain the examination. Of course, you have to explain, now it will detect. So you have, so you have to explain we're going to do exactly like if I'm doing abdominal examination, you have to explain to the patient that I will do abdominal examination that will include me exposing you from the mid chest to the lower to mid thigh as well. I will have a look on your belly and I have to palpate and have to touch you. If you feel any pain, just let me know. It will not be that painful, but if there's any discomfort, just let me know. So my examination. Obtaining consent, then you'll ask the patient if you need the chaperone to be attending to the examination, and then you have to ask about the consent. Still a little too fast. Okay. So yeah, we're currently following the feedback, the real-time feedback to enhance the presentation skills. So you have to ensure the privacy of the patient and obtain a good exposure to the area that we want to examine. You have to wash your hands. Then you have to sort the examination. You'll start with the general examination for the head and neck, checking the signs of systemic diseases. There's some sign of focal disease as well. Examination methods are inspection, palpation, percussion, and auscultation. But then you have to apply those methods accordingly. So speaking about head examination, that includes skull and hair examination, face examination, eyes, nose, mouth, throat, and ears examination. Skull, you have to inspect for the shape, size, to help to diagnose some syndromes in children and some neurological conditions. Here you have to look for the hair distribution, hirsutism with eyebrows, face inspection for facial expressions, asymmetry, any rashes, pigmentation, certain faces like diagnostic faces like an acromegaly, trisomy, and some thalassemia faces and so on. Palpation, you have to palpate your hand, you have to take a consent for the patient, you have to explain if there's any pain, if there's any tenderness, and you have to palpate in the head looking for swelling, tenderness over sinuses, and then test the face movement to test the neurological supply. So I have to ask the eye closure, lower face and mouth movement, and brows. So that's it. So when I'm ending the presentation, we're going to have a full report about the presentation, which includes 5 main areas, which we will see now. I'm going to close. Okay. Okay, there's something wrong. We ran into a problem. Not sure help markers are per PowerPoint. I know what's wrong, actually. Something went wrong. Let me try to. So this is from the offline. You open the presentation, you go to the slideshow, and then you will find rehearse with coach. Again, it will appear, and then show real-time feedback. I'm just going to go very fast through the slides. Clinical examination, today we're going to speak about the clinical examination, which includes a lot of things, but clinical examination is a part of diagnosis. It's help us to reach out to diagnose alongside the history taking, differential diagnosis, history taking, investigations. Approach to the patient, have to introduce yourself, to confirm the patient age, identify, explain examination, obtain consent, ensure privacy, obtain exposure, wash your hands, and then doing the general examination of the head and neck. Mostly you have to examine the head and neck that shows sign of systemic illness, sometimes shows sign of focal diseases. Examination methods used are inspection, palpation, percussion, and auscultation. Specific head examination includes skull and hair examination, face, eyes, nose, neck, mouth, throat, and ears examination. Examining the skull and hair for shape and size, hair distribution, hirsutism, and then you have to look at the eyebrows. Face, you have to inspect for facial expressions, if there's any asymmetry, any rashes, any pigmentation, certain faces, but also diagnosis sometimes like in acromegaly, trisomy 21, and thalassemia faces. Have to palpate, you have to ask the patient if there's any area of tenderness. You have to palpate for the swelling, tenderness, or sinuses. Test face movement, brows, eye closure, lower face. So just like, so that's it. The previous rehearsal, you could clearly see that how we get the real-time feedback. I just want to show you how will the. Okay, can you see the now the report?
No, still loading.
Now, can you see it?
No, actually, we see like a blue square page.
Because it's giving me, please move this window away from the shared application. I'm not sure if it's blocking it for the confidentiality because it's like confidential. So I'm not sure if it's blocking it from the.
Yeah, I think probably it is being blocked.
But let me try again to show you a full screen. Maybe it's blocked. Okay, can you see it right now?
Yes.
Yeah, it says your rehearsal report.
Yeah, it was blocked from the Zoom. So because for the privacy and confidentiality. But anyway, this is the review of the report. So it gives a summary that total time spent is 1.32 minutes and slide rehearsed were 80 slides. Then it will give a comment about using filler words. You see, like it's written that you use a lot of and so you have unnecessary pauses. Repetitive language said nice work. Your variety of words choice will help keep your audience engaged, so that's good. Inclusiveness, also great comment, like you use like inclusive language as an excellent. Then you have a comment about the pace and the rhythm of speech, and just either slow or fast. Now it's like an average like 138 words per minute. It's all right, just keep it up. And then it will give a detailed analysis on your average pace over time, over slides, and over the progress while you're presenting. So we'll get to know where you were a bit faster or a bit slower. And then on the right, also it will comment about the pitch and the low tone that you're using when it's good, like monotonous, if it's high, if it's low, and in which slide, in which time. And then if there's something wrong, it will tell you on the real feedback, in real time feedback, that you have to raise your tone, you have to speak a little bit slow, you have to do that. So you see the track record and the progress and the improvement throughout the final report. The originality, it will give you, if you like were reading just simply the slides, like what I did in the second presentation, which was rehearsed, and then we get this report. So it's telling me try to avoid simply reading the slides. And then it gives actually the exact slide, which like I just read it. Here the slide you might want to work on, which just I have listed them in points without any explanation, without any extra note or something. So that's how the report works, and that's how you could have a look at your weaknesses and you work to improve them or enhance the skills. I wanted to show you that how can you use the camera on and also have a comment on the body language, but I think it's blocking. I cannot use two cameras in the same application. I'm not sure if that's technically able, but I've tried it before, but not sure why it's blocking. But anyway, that's work on the online version. If you have a subscription, an online account on the Microsoft, you just have to open, and then as I showed, you have to select that rehearse with body language, and that it will give you also real-time feedback on your body language skills. Like if you're like moving your head around away from the camera, it will tell you that please be centered and look at your camera. Like if you're too close to the camera, it will tell you that please come away from the camera. If you're like blocking or using your hand in front of your face, it will tell you that do not put any object in front of your face. So it will give you real-time feedback about your communication skills. If you're not keeping eye-to-eye contact, it will tell you please keep to eye contact to the camera. So that's also a good area to enhance and a good area to look at the online version. So it's summarized. It's as a summary, it's really a great tool, and it's really very excellent in self improvement and in self coaching using the artificial intelligence which built into the Microsoft. I think that's all. I'm gonna have some few questions that frequently asked, and also I'm gonna share it again. Okay. So just before we go into the questions, final tips for effective rehearsal. Just be natural, try to speak yourself. Speak natural like you're really presenting realistic on a live audience. Please take the feedback seriously, as it's really give a really good feedback and analyze your presentation skills and use them to make any necessary adjustment and improvements. Practice, practice, practice. Repetition help you to be a master. So the more you practice, the better you become. Try to record and review your recorded sessions, so at least you can have a track record of your report and all of your video recording, so you can watch yourself where you're presenting after you present. So these like just basically 4 tips for effective rehearsal and coach using this tool. Okay, come and ask questions. What kind of feedback did the rehearsal coach provide? I just explained it provides real-time feedback to your presentation skills, which include the clarity of language, the pronunciation, the inclusiveness, the pace, the rhythm, and the using of filler words, and also the body language. Okay, is the feedback from rehearsal coach immediate? Yes, it's immediate. It's real-time paced feedback, so you can use it as to improve yourself while presenting. Can I use rehearsal coach for any type of presentation? Yes, you can use for any type of presentation if it's presented through the PowerPoint, Microsoft PowerPoint. Do I need internet connection to use the coach tool? You don't need to have internet connection. You can work offline as well. But you make sure that you have the like the subscription or account on the Microsoft, like the latest version of the Microsoft download in your PC or your laptop. If the feedback from rehearsal confidential, just we proved that, right? It's confidential, it's sensitive, it's never shared with third parties, and you have your own like records in your laptop or computer. Can rehearsal coach help with language specific feedback? Not really. Not really. It's comment on the delivery style and the content, but it's not it comment on the delivery style, not rather than the content of the language. So, but however, it just sometimes offer general feedback and just suggestion of the clarity and inclusiveness of the language, but it's not like for the language purpose mainly. So, is the rehearsal coach available on all versions of PowerPoints? I think it's only on Microsoft 365 subscription account. So if you have account on that, you can work on online. If you don't have, then you have to get the validated license for the Microsoft PowerPoint or Microsoft package, so you can use that offline as well. Does the rehearsal coach support multiple language? Yes, to some extent. It's available like in specific language, but it supports multiple language, and you have to check the most updated recently language also on the Microsoft website. Can it be used for a group presentation? Unfortunately, no, as still it didn't have like a way to specify which one is presenting right now, or to give individual to give individual feedback while presenting as a group. So I advise to use it as an individual tool to get an individual feedback, real-time feedback, so you can improve yourself. So you will have a general report for all of the presentations. You cannot judge which of which. It will give you just a final feedback and a final report, unless you just want to follow the online real-time feedback. Okay, that's it. Thank you for your time. And if you have any question, we'll be more than happy to answer. Thank you so much. I'll give it back to you, to Dr. Nader, if you.
Great presentation. Thank you so much, Dr. Yassein. Yeah, it's useful to use it as a tool, and especially when you want to get confidence in a topic, or you want to get some skills as far as presentation. You're going to present when you are first year resident, second year, and then later on as you go along. So it's better to develop these skills from now on, and it will help you identify some of the mistakes or something that you do that you don't notice usually. As Dr. Yassein mentioned, for example, I'm saying or but I don't notice that when I'm presenting, but the report will tell me either as I'm speaking, there's some pop-up notification that I'm using or as he mentioned, the camera will tell you if your face is looking at the camera or you are looking somewhere else. So it helps. So practice will make it easier for you guys. Thank you so much again.
You're welcome, Doctor.
And as far as the presentation itself, I think you mentioned that you used the AI to create the presentation, which is good. So
yeah.
Can you tell us more about that? What prompts did you use? What did you ask the AI? Which one did you use? Google or ChatGPT or Microsoft?
I use Microsoft Design for designing the illustration that have been put on the presentation, and it's called Designer, Microsoft Designer. So you can write any prompt for the illustration you want to, and then it will really give a lot of options, and you can keep generating till you get the one that you have imagination for. So it really very that's amazing.
Excellent. Awesome. Yeah. Excellent. Thanks for sharing.
You're welcome.
Perhaps one day you can show us how to do that.
Sure. Inshallah.
Inshallah. So if no questions, no comments, we can move on to the next topic. Do we have Dr. Nada?
Yes. Hello, Dr. Nader. Can you hear me?
Yes.
Hi. Yes, I'm
How
here.
are you?
I'm going to be presenting about the Canva and how to use it for video editing.
Sounds good. I'm going to give you the host.
Okay, thank you.
So it's yours. Thanks.
Thank you. Okay, everyone, can you see my screen?
Yes.
Okay. So we're gonna start just to give you a feedback, like what is Canva itself. So Canva is usually used for anything, honestly. It could be used, one of the many functions is video editing, but it could be used for presentations, for social media, like there's a lot of stuff. So we're gonna focus today about the video editing and how can we use it in like the research itself. So in my case, we have a poster presentation. So we're doing it virtually. So we need to provide like a video of us presenting this case. It should be like it have like text in it. It should have the poster presentation in it. It should have our videos presenting it. So we need editing in that case. So that's why we're using Canva. Let me just gonna. Okay, just wanna control it. Okay. So let's start from the start. So here we have it. We started with Canva. We pressed like the video button. So in that case, we're gonna start like this. We don't have anything in that case. So we're gonna start from the start. We have, first of all, we have pages. Can you see page 1? And then we can add pages here. So we have 1, 2, and so on. So we're gonna create a video from the start. What is a page? So for example, let's say you have a few presenters in this poster presentation. The first person is gonna present and then someone afterwards. You wanna change the background for the other person. You wanna put a new video in that case. So I would recommend using a new page in that case. It's gonna make things much easier. So let's start. For example, we want to put first the poster presentation. You can see all of these icons. So we have the uploads. Usually you're gonna put it in the uploads and you're gonna just choose it. Just to put you in mind, if you're gonna put a PowerPoint presentation, you're gonna upload a PowerPoint presentation, it's actually gonna be in design. It's not gonna be in the uploads area. And when it's put in design, it's usually very hard to actually like manipulate it. So it's gonna be put in the middle and you're not gonna be able to put it on the right or on the left. So I would recommend using a snipping tool, for example, to crop it out from your own computer, like have a screenshot of it, and then you're gonna upload an image. And like in this case, so we have here an image. So once we press it, it's very easy to manipulate in that case. Like we have it here, I can just enlarge it and I can put it on the right, I can put it on the left, I can do whatever I want. So it's much easier in that case. Okay, so let's say we put it here. We want to do something to the background. So we have here the options for the background color. So we usually are gonna give you a few options. They're gonna be from the colors of the thing that you put in. Like let's say you put a picture. So as you can see, they give us a few options. Some of them are gonna be like some of the colors that we have in the poster presentation. So let's, for example, choose this color. Now we want to add the video. So in that case, you're gonna have like a video recorded. So you have two options actually. You can record it in your own like webcam from the camera in your laptop, for example, and then you can upload it here and it's gonna show up on the videos. So that's one of the options. The other option is you can record yourself. Record yourself is another option. We can use it in that case, for example, and we can use, I'm gonna use one of the pages. We're gonna use one of, let's say, the videos that they already have here. And then the other one, we're gonna record our steps just to see how it works. So let's start. So as you can see here, there's apps on the left. So when I choose apps, it gives you a lot of options. Some of them are photos, audios, and so on. So these are like templates, things that already Canva have. You can just choose from them. Since I don't have anything pre-recorded, of course, in your presentation, you're gonna use your own recording. But in my case, since we don't have anything recorded, so I'm just gonna use one of the templates. So as you can see, they give us a few options. Let's, for example, choose one of these. Let's choose this one. So here we have it, and then we're gonna edit it. So as you can see, this is too large. We don't want it to be over the poster presentation. So I'm just gonna put it like this, and I can just move it here. So I don't want it to be like this. I want it to be more focused. Just remember, when you use this one, you're enlarging the whole thing. When you're using these ones, like the ones, as you can see, it's actually cropping it. So put that in mind when you're using it. So let's say we're gonna crop to the face like this. We're just gonna put it here and like this. And here we have it. We have this. We have the first presenter. I think this would be best in that case. So you have the flexibility to change anything at any time while you're doing it. And I think it's very easy to actually apply. So let's say, for example, I wanna, for example, I have my video for 15 minutes. I actually just want the first 10 minutes. I don't want the whole 15 minutes to be put here. So you have this option. Can you see the trim? So you choose that option and you can just like this. You're gonna decrease it either from the front or from the back. And this is cropping your video itself. So let's say I just want it to be 10 seconds in that case. I press done and here we have it. So that's our presenter, that's our video. And you can you see here we have the audio. So in that case, you can make it either with the audio or without. Of course, since this is a template, we don't actually have an audio for it. So it's not gonna have in that case. But when you're doing your presentation, you're gonna have an audio. So you have the option to either use the audio or not use it. So here we have it. We have this at the start. Let's say I want to present this presenter. I want to have their name downwards because we don't have enough time to actually present themselves. We have like a time limit for the poster presentation video. So we're gonna press text at text box. Here we have it. We got it here, for example. And let's say Dr. We're gonna double click on it and say Dr. Mayra, for example. So here we are. Okay, so I think the black in that case doesn't look as good. So we want to change it. So we can change it from here. So we have the text color. We're gonna change, let's say white in that case. And here we have it. You can place it wherever you want. Let's say in that case here. So here we have it. We have the first presenter. And we have it, in that case, it's 10 seconds. Of course, the presentation itself is gonna be longer. Let's say each, for example, each presenter can have like a minute or something. Okay, so we want to add the other presenter. So she finished her part. In that case, we want to add the other presenter. I would recommend just using a new page. It doesn't take much time. And it's gonna be much easier to actually manipulate it. So let's say here, we're gonna use the same poster presentation, of course. Also, the good thing about using another page, as we're gonna see later on, we can animate it. Like we can animate between the two presenters, so it would be like more smoothly. It seems smoother to the audience itself. So let's, for example, we're gonna do almost the same thing. We're gonna put it here. But let's say, for example, I'm doing a new presenter, so I don't wanna use actually the same background. This is also an advantage of using another page. You can manipulate or change the background. So let's say we're gonna use this color. So here we have it. So a new color, as you can see, the first one had a different color. I put it in a different place and I used a different background. And I'm gonna add another video. So let's say, for example, you're gonna use another video from here. We can use the record yourself at the end. So you'd have something to compare to. Okay, so I'm using another video. Of course, this needs editing. So we're gonna do the same thing. Everyone, if you can practice with me. So what's the next step? We're gonna put it like this. And let's crop it. So as you mentioned, these are for cropping. These are for enlarging, and then you put it here. Here we go. We have it here. I want to trim it as well. Then we're gonna trim it. We can trim it from the back. We can trim it from the front. I'm trimming it from the back to be 10 seconds as well. So here we have it. So we can see like a preview now for it. And then we're gonna do like the editing at the end. So let's say I wanna play it. Of course, this is the precursor. We're gonna move the precursor wherever you want so you can start the playing of it. So here, as you can see, she's speaking. There is no audio on this one, but if we have audio, it's gonna be playing as well. And then she finished. I want you to see the transition. So as you can see, the transition is abrupt in that case. Let's say you don't want it to be as abrupt, then you can use an animation in between. So that's an option. For example, you have, let's say, for example, I actually want like a few seconds in between them before we go to the new presenter. So you can add a new page and just leave it blank. And let's say we're gonna change the timing on it. So I want it to be very like just a few, less than a second, just something to be pausing in between. So I'm just gonna do it like 0.4 seconds. Let's play it once more. So this is an option. If somebody prefers it, we can do it like a blank. Also, as you can see, I'm manipulating it from here. I'm gonna change the seconds. I can change it like this as well. You don't have to go up and like change the duration. So this is another option in that case. Okay, So let's say we want to animate it. Okay, so here we have it. So we animate it. You have all of these options. Just remember, this is like the free version. There's of course a paid version, and you would have more options, especially from what I've seen so far, especially from the animation perspective. Sometimes the animation you wanted, for example, let's see the options. You're gonna see what's limited. So in that case, there's no limitations. As you can see, we can use both of them and it doesn't cause anything. But if I remember, let's see Photorize. Can you see here? Photorize, for example, we have like this, this crown next to it. When it's a crown, it's usually the paid version. So in that case, you have to pay to be able to manipulate the intensity, for example. In my case, I can't, so it just have to keep that way. And the direction, the same thing. So either choose one of them and just keep it as it is, or use the paid one, whatever you prefer. You have the two options. So let's say we're gonna use both. This one, you don't even need to use done or anything. Once you click it, it's already saved. So we're gonna say the same thing on both. So both is on entry and exit. So at the start of this page, at the end of this page. So that's what you're choosing. Okay, so here you have it. Let's start from the start once more. So as you can see, there's an animation at the start, just like the start of this presenter. And then at the end as well, we're gonna see it. And then there was a slight pause, the one that we put in between, and then the animation, the presentation, and then we're gonna see the same thing at the end. So this is a tutorial. Let's see if we can record ourselves. So when you record yourself, sorry, I'm in the car, so didn't have time to go to my home before the presentation. So as you can see here, you have this icon. I can change its shape. Let's say I want it to be the same as the other one, so I can use this one. I can put a filter on my face. I can use effects and so on. So let's say I want to put it here. Of course, afterwards, you can change anything that you want, like the shape, you can crop it and so on. So I'm gonna use it. Let's record and see how it went. So it's giving you a timing. Okay, hello, my name is Dr. Dahroug. We're gonna present today a poster presentation about a case of Alzheimer's dementia in a culturally diverse patient. The presenters are gonna be Dr. Dahroug, Dr. Nidhal, Dr. Myra Mizoni, and Dr. Nader Abdurrahman, and this was done in the Telegeriatric Research Fellowship. And then we're gonna start with the introduction. Let's keep it there. So done, and save and exit. Okay, hello, my name is Dr. Dahroug. We're gonna present today a poster presentation about a case of Alzheimer's dementia in a culturally diverse patient. Can everyone hear the audio?
Yes.
As you can see, okay, that's good. So as you can see, this is an audio. It's very clear. The presenters are gonna be, and you can crop it and do whatever you want. So let's say I'm gonna crop it here, gonna crop it here. I'm just gonna remove this one actually and just put this one instead of it. So here you have it. So it's the same thing, but in that case, you want to record yourself while you're actually doing the video itself. So this is a good option. But usually when you're doing like a few presenters, it's easier for everyone to do it at home whenever they want the video itself. And then they can send it to you and then you can just add it here. Or you can record yourself, you can share it and they can have access and they can record themselves and put it here. So you have both options. So whatever you prefer, you can use in that case. As you can see here. So let's try and play it from the start and see how it went. So the precursor, I'm putting it at the very start and I'm playing from here. So as you can see, in that case, the video appeared before the poster presentation. That's because I put an animation on. Let's say I want to put something, let's see. Let's see it before the cropping. There was an option I want to use that I can actually layer it. Dr. Dahroug, my name is Dr. Dahroug. We're gonna present it. Okay, hello, my name is Dr. Dahroug. I think it only appears when I'm doing two videos on top of one another. So give me a second. I'm gonna add a video here. I want to show you if you put two videos on top of one another, I remember there was something that you could do. Just want to use it here.
Nada,
Mhm.
if you click on the video and then there is a delete and 3 dots.
Oh, so it's the 3 dots. Okay. Which one were I using?
Go down.
Timing, I think. Yes, thank you. I was looking for that one. So let's go with this one, and let's keep with this one, and we're gonna do the same as Dr. Nidhal mentioned. So we're gonna show the timing. So timing is shown here. So can you see this purple one? So this is new. This wasn't there before. This is just the video without the other things that you have put into the page. So let's say I don't want it to start from the very start. I want the video to start from here, for example. I want to show the poster presentation first. Then you're just gonna leave it here, as you can see. So the video comes in later. So that's an option if you want to use it. It's also a good option if you want, let's just use this as a demo. So let's say I'm gonna put 2 videos on top of one another. So I'm gonna continue this video. It's a good option if you want to put 2 videos on top of one another. I'm just gonna give you here. Because you can have the audio in the background, and then you can have like a video pop-up. Oh, I don't want to put it here. There we go. Okay, so can you see here we have 2 overlapping videos? Let's say I want this, of course, not in that case, but just in general, if you want to use the video for any other cause. So Mayra Mizoni, for example, is here. We can use the layering. So I can say send it backwards. So it wouldn't appear on top of the video. And then I want to show the timing on this one. You can see. And I want it only to appear for a second in between, for example. I'm just gonna give you a demo, so if you want to use it at any point, you can. So let's say this video is playing. So the other one is gonna pop up. The presenters are gonna be Dr. Dahroug, Dr. Nidhal, Dr. Mayra Mizoni, and Dr. Nidhal. So as you can see, the one that has the audio in that minute is working, but the other one that you are gonna see, the one is that you put on the front. So in that case, it was that video. Just wanna put it there in case anyone wants to like use like overlapping videos. So that's a good option. Just gonna remove it now. Okay, so here we have it. That's like a demo. Let's, for example, see it all at once. Okay, hello, my name is Dr. Dahroug. We're gonna present today a poster presentation about the case of Alzheimer's dementia in a class 3 diverse patient. The presenters are gonna be Dr. Dahroug, Dr. Nidhal, Dr. Mayra Mizoni, and Dr. Abdurrahman, and this was done in the TGRF Research Fellowship. And then we're gonna start with the introduction. Let's keep it there. So done. And then the other one plays, as you can see. And there was a pause in between. You can increase it, you can decrease it, you can do whatever you want. And here we have it, and that's that. Okay, if anyone has any questions, please let me know.
Thank you so much, Dr. Nidhal. This is excellent tutorial or presentation. Thanks for sharing and showing us how to do it.
Thank you so much. Thank you. If anyone has any questions, please feel comfortable to just reach out to me. Thank you so much, Dr. Nidhal.
Thank you. So last part will be updates. Any updates as far as the projects? Dr. Mafaz is not here, but Dr. Mafaz and her team has an abstract that was accepted, and she will be presenting in Boston in October, the CHEST conference. So their abstract will be presented there. So I think she will be in person. Congratulations to Dr. Mafaz and her team. Thank you so much. Dr. Naud, go ahead.
Yes, I was about to say the same thing. I don't think Dr. Mafaz is in the meeting today, but the paper that we worked on e-cigarette and the clinical effect of e-cigarette on different organs has been accepted to the CHEST journal, and she will be presenting it on October. So thank you for everyone, and thank you also all of the team members.
Congratulations to all of you. Thank you, Note. Any other updates or any other ideas, research questions, research projects? Hello, Dr. Amal. Go ahead.
Hello, Dr. Nader. Hi, everyone. So I wanted to update you regarding the latest application, the renal wellness. Last week we completed all the steps of uploading the mobile application to the Google Play Store. So we uploaded in Dr. Isra's account. But in the last step, they asked Dr. Isra to verify that she has an Android device by scanning a QR code that is present on the Play console itself. But unfortunately, Dr. Isra doesn't have an Android device. She uses an iPhone device. So she's trying to look for a nearby Android device just to complete the last step.
Sounds good. Thanks for sharing.
You're welcome. Thank you very much.
And congratulations to you and the team as well. Thanks.
Thank you very much, Dr. Nader. Thank you for the opportunity.
Dr. Haifa. Go ahead, Dr. Haifa.
Sorry, I'm just like, I want to mute myself. Thank you for giving us this opportunity to discuss our, things that we have to discuss. Right now I'm working on the, trying to do a systematic review on gut microbiota and the correlation with the graft-versus-host disease and the immune reconstitution. So while I'm doing research, especially in pediatric, while I'm seeing some of studies that they focus on this, specific topic, but they are when you just read for the introduction or the conclusion, or they give you, for example, numbers that they refer to another studies. Can I say this study also, for example, agree with, for example, this topic or something like that? Because most of the studies, they will give you, for example, numbers that refer to other studies that they use it as a reference. So does this study means it also, for example, agree with the certain topics, or I cannot say that? I hope my question is clear or not clear.
Anyone from the seniors can answer?
Sure, Dr. Nader. Just I want sure that I understand the question. So you say that
you're asking if the specific articles are referring for another articles that has been talking about the gut microbiota and graft-versus-host disease. Does this articles is considered one of them, right?
Not considered one of them. For example, they are referring to another articles, but can I say this article is also agree about this topic or not?
Okay. That's clear. So mainly for systematic review and meta-analysis, the studies that should be included in your systematic review should be agreed on a specific PICO, which is, I think you are familiar with, which is the P for population, I intervention, and C comparator, and O the outcome. So if the specific study does refer to another articles out there, but they are different in the PICOs, this doesn't mean that they are in the same topic. You got me?
Yeah, because I get you. Yeah. I mean, like, as you mentioned, yeah, because like they're referring, I'm specific in pediatric, but when they're like, they're giving their mention to another, like, for example, adult. So I cannot say these are, for example, agree with the same, I mean, like, they also agree in the same topic or something, because, you know, most of the studies, like, they are compared, because it's like, it's not as, you know, like, there are not as much too much studies regarding the pediatric, even if they have like studies regarding pediatric, they are like still small samples, not like as the adult. So for example, when I'm just reading the articles in the introduction, it's about the pediatric, but when during the introduction, they are referring to another articles, for example, for the adults. But you know, like in the conclusion, they, you know, like they might, you know, like find similar finding, or like they agree, and but they need further, you know, like researches, or like they encourage, you know, like further studies regarding this topic. So
right. So in such a case, for example, let's say we are talking about just for making the idea clear. Let's say, for example, we are talking about diabetes mellitus in both adult and pediatric population. So if we want to see the effect of metformin among the pediatric population, but there is some articles out there that are measuring the effect of the metformin among the adult population, this is considered another idea or another topic, because the population are different here and the effect will be different, of course.
okay. Just like, because I have, you know, like in the studies, they said like it's in pediatric and the sample is in pediatric, but for example, in the introduction, they are referring, but it's like in the conclusion and the study, I mean, like the results, they agree. But for example, I mean, like they still give us, for example, you know, like they are comparing comparing to the adults, so and so. So they just like most of the studies, they're comparing it to the adults. So I'm not sure, I mean, how to.
So can I ask you a question?
Yes, sure.
All right. So what is your population? Is it pediatric or adult?
Yes, pediatric, yes. And also the topics that I included in my studies, it said, for example, it said it's on pediatric, and the sample is on the pediatric. I mean, like
right. If the sample is on pediatric population, this is an include for you, but the references that they are referred to, which is an adult study, that will be an exclude for your case.
Yeah. I mean, like, I didn't exclude, but like in the same article, for example, in the same article, they are like, you know, like when you read an article, and then they give you, for example, numbers in the same article. These numbers are referring to for their as a reference in their article. So their reference is not like all specific for pediatrics. Sometimes their reference is like also for, you know, like as an adult, you know. So that's why I'm just confused, you know, like did you understand what I mean exactly?
So are you asking that if there is a reference for adult, what does
No,
that
no,
exactly mean?
And for example, I'll give you the top. I mean, like the studies on the pediatric age group. Okay, but when I read the articles, yes, and it said for example, like gut microbiota composition, predicting infection risk during the chemotherapy in children with acute lymphoblastic leukemia. For example, this is one of the articles. Okay, so it said in children, but when I just like open the like when I just read the article, I found like they are like their references, not just, for example, their references, but they are, you know, like the reference that, like the numbers that they gave, their reference is not specific for pediatric. They are also like, you know, like they are using the reference to just go, for example, they said like after they give you a sentence and then they give you a number. So when you just like click on that number, I found that this study is not like, for example, specific for pediatric. This is for an adult, you know, like adult people or something like that.
Right.
Yeah. So can I just say they are also agree about the topic, or like I cannot depend on this, for example, information, because it's not.
So you want to use these data that are present in adult populations as an supportive for your data, right?
Yes, yes.
Yeah, I can actually do it.
Yeah,
Because
actually, yeah.
yeah, I hope that answered your question.
Yeah, I mean, like, if you just like, if you would like, so we can, I mean, like, if you just give me your email or whatever, so we can discuss this together if you would like, if you have time. So
Right, no problem. I will add my number here, and you can contact me through WhatsApp.
okay, thank you very much. I really appreciate it. Thank you.
You are welcome.
Thank you both.
Thank you.
Dr. Lina, you have a question or comment? Go ahead.
Hi, Dr. Nader. Hope you are all doing well. I just want to clarify from Dr. Haifa, because I think I got what she means. She's doing a systematic review on original data. So the papers she's talking about are case reports, case series, cohorts, etc., right? So I think if it's a paper population is pediatric, but they use quotations or reference in the introductory or the discussion from adult population, but what
Yes,
they are referring, the original data is pediatric population, it can be included in a systematic review about pediatric population. I didn't get what reference you mean, what the data they are referring to and they are using an adult population for is it the
no,
main
actually,
paper?
actually, they most of the like it is on pediatric. The study that I'm using, it's I mean, like I know that is like it's in pediatric, and I like I check about the population and the age of the patient and everything. But as you mentioned, that they are, for example, quoting because it's like it's not as much studies on pediatric as in
It's
the
not
adult.
relevant topic for research. I got what you mean. It's not a relevant topic. There is no much published data to be used while writing the introduction and the discussion section, right?
Yeah, I mean, like, for example, I'm still like, the topic is the studies that I'm choosing. It's also, for example, the including my study, it's in pediatric. But in the same, I mean, like in each one of them, they are referring, they are doing in the pediatric, but they are still referring to the adults. They are doing in pediatric, their samples in pediatric, but they are like referring to the adult population because they, so for example, they give you a synthesis in pediatric that what we found. However, in the adult, we found it like, for example.
Okay, it's okay. Maybe they are just using it as because of there is shortage in data related to the pediatric population. But if the original patient in that case report is a pediatric fitting your inclusion criteria that you chose to do while doing the Prisma, I think it could be included. There is no there's no such preventing element that this paper should be excluded. Even if while they are discussing their case, they used adult data or adult, let's say, scores or like that. Maybe because it's a new topic, maybe it's not fully digested in research field. But if the original patient and the original data they are presenting is fit to your inclusion criteria, then
I think she dropped out.
Yeah. Sorry, I cannot hear you anymore.
I think she lost connection.
Yeah. Even thank you very much. Thank you for your help, all of you. Thank you. I really appreciate it. Thank you.
Thank you again. Thank you all. Any other questions, comments, or suggestions, ideas, research projects, updates? If not, then I'd like to thank Dr. Yassein, and all the presenters from today's meeting, along with all the attendees and those who will come later. Thank you so much, and I really appreciate your help with this program. Thank you so much again. Have a wonderful day or night. See you next week, inshallah. Dr. Yassein, go ahead.
Okay, thank you so much for all of you for attending, and it was really very informative and fruitful discussion. And on behalf of Time Group 1, we would like to thank all of you for attending and reading this discussion as well and moderating this session, Dr. Nader. So thanks all for the member of group line group and for the Dr. Miriam Muzini with the group there as well. Have a good day and see you inshallah next week.
See ya. Assalamu alaikum.
Wa alaikum assalam.